Hey everybody, and welcome back to Bottomless Coffee with Jerome. In this episode, I want to give a special shout out to Advocates for Better Health and the Minnesota Department of Health. This cold, flu, and COVID season, please do yourself and your health practitioner a favor and get up to date on your vaccinations. Today, we're going to be talking about living healthier lives with Dr. Tom Kottke. Dr. Kottke is the Medical Director of Well-Being at HealthPartners and Professor of Medicine at the University of Minnesota. He has also authored or co-authored an incredible number of articles, reports, presentations, and reviews, all centered around how we can live better lives. Welcome, Dr. Kottke. How you doing?
I'm doing very well.
Great, thank you. Thank you very much for being here. Can you tell us just a little bit about how you became a doctor?
Sure. It was sort of congenital.
Okay.
My mother was a public health nurse, and she was an organizer. And so I think it started sometime a couple years before I was born that I was assigned. I was assigned to be a doctor. But ever since I can remember, maybe age 3 or something like that. And that, that's about when kids, really start thinking about occupations.
Really? That young?
Yeah, that young. And that's when also they decide whether they're going to smoke or not.
Oh,
because they look at adults and, adults smoke or adults don't smoke, or they do this or they do that. And so they start seeing role models. And so
we're jumping right into the public health stuff, which I love. What I think I'm hearing from that one example is that kids start mimicking adults at maybe a younger age than I expected.
Sure.
I'm a homosexual man. I don't have any kids. Not yet anyway. We'll see what my husband has to say about that in the future. But I wouldn't have expected like 3, except for the phones. I feel as though they're often on the phones. And so you kind of think that your involvement at that intersection of public health and being a doctor started because presumably your mother was organizing, maybe even at the home while you were youngling?
Absolutely, absolutely. And my father was also a physician, and so and an uncle, and so it was, But I did try to escape when I was an undergraduate and majored in anthropology. And this was during the Vietnam War, and very interested in the whole idea of culture change and development, and we thought we could change the world. And we talked about after the revolution, but what we didn't understand was we were going to be the ones getting our asses kicked versus the other way around, where we thought we were going to win. We didn't understand the economic value of war to certain individuals.
Well, I think we all have a pretty intimate understanding of that these days.
Yes.
Do you find that studying of anthropology has been maybe not something static in terms of your relation to it during that Vietnam era, but something that you just kind of kept up with over?
Oh yeah, for sure, because
the world's it's kind of a crazy place right now.
Yeah, but it also is how we change society today. How does society change? We know, for example, that social movements spread through people knowing each other. All of the world's great religions started among friends. I mean, it wasn't just, I'm not religious, but just take Jesus. I mean, he did not just go out and grab some guys off the road. Sure. The original apostles were people he knew. Muhammad started through his family, and the same with Buddha. And so when we think of social movements, and this is one reason to get out and meet people, is getting to know them and letting them know you, so that when you come back to them and say, hey, Jerome, let's overthrow the current order and create equity. You say, yeah, I know this guy. He's okay. He's okay.
Yeah, I have been approached with that suggestion or that suggestion for action several times.
Right.
I've taken it up twice. I agree that it is who you know and the examples that you're around that really influence who you are and who you become. Do you find that you've brought in that spirit, your mother's spirit of organization into your work as a doctor?
I'm much more disorganized, unfortunately. So there's two structures of society. There's the bureaucratic, which is highly organized, and then there's sort of the hunter-gatherers, where the say guy's a really great hunter, and so people follow him. Follow that person, and it's low structure societies, and I'm sort of the low structure guy, but I do understand that we need. In complex societies and dense societies, we need structures, and yeah.
It's interesting. I was on a podcast episode recently talking about my relationship with my husband and how in my earlier years I was very much very chaotic, a lot of energy, kind of all over the place. And then we met, and he provided this kind of structure. A bureaucracy, a very intimate bureaucracy that helps me navigate all of this energy. And it's interesting to hear about these two sides of society and how maybe it takes the two working together to be productive.
And you're absolutely right, because there's different role in a group. Different people have different roles. And when I was a medical student, I sat on the Council of Deans and Directors. And Meade Cavert, who was one of the deans, he was always raising the question, how do you really do this? How is this really going to happen? And it really frustrated me. But that's a role that has to be in the group of, how is this really going to work? And it's a question somebody has to ask, and it's very important not to get mad at those people, because they sort of do, you have this dream, and you're telling a really good story, and and creating this image, and somebody says, well, how's this really going to happen? And
I feel like in families, that's often the voice. It's like, well, how are we going to pay the mortgage if you do that?
Yep, exactly.
That's a great idea, but how do we keep the lights on?
Exactly.
Well, so you've written a number, or co-authored a number of publications. I think when I tried to count them, I stopped at 50.
Oh.
Yes. Yeah. And that was just one section, so there was a lot going on there. And what I could kind of glean, I wasn't able to read all 50, but what I could glean is that you seem to really care about populations as well as individual people. Obviously, you're a doctor, you're with people one-on-one all the time. But as someone involved in well-being, and given the subject matter of the papers that you're writing, it's like, oh, this guy really cares about what happens to us, and us is in the really wide sense. So, is that from your mom, or where does that come from?
Yeah, and maybe, I don't know exactly, but it's probably also that cultural anthropology, this social.
Sure.
Yeah, the first, you mentioned 2009 in the background.
That was the earliest publication I could find on that website, but I feel like I should have done more Googling to see.
Yeah, I went back, and my first was in 1973, and the title was Revolutionary Judo and Doctors for Change. And so,
judo?
Yeah.
Oh.
Well, it was borrowing that. Revolutionary Judo was Saul Alinsky's. He was a community organizer in Chicago. It was his term of getting the people who had the power to overreact and sort of getting hoisted on their own petard. So that made the leadership in the medical school sort of nervous.
Okay. Sure.
No, 2009 was a paper I had been working on for about 30 years, and it was calculating the benefits of basically creating healthy environments and people eating well, exercising, not smoking, etc., before they developed cardiovascular risk factors, treating acute events or than following up. And what I was able to calculate is that if we delivered perfectly the care we know for people having acute events, they're in the hospital, we could, in a population ages, let's say 30 to 84, we could prevent or postpone about 8% of any deaths, all deaths. But if we prevented and people did their exercise, ate well, it would be about 35%. And secondary prevention, treating hypertension, getting people, basically ambulatory cardiology, another 24. So we could prevent or postpone in the ambulatory setting and in the community about 60% of all deaths, prevent or postpone.
Wow.
Versus the asymptote for acute treatment is about 8%. And so that really solidified my commitment to communities and making sure people had access to nutritious foods. And access means not just is it physically there, but can they afford it? Those kind of things. Clean environments. I've worked in tobacco, freedom from tobacco for 40 years. And then we're working now on access to physical activity. And big problem is fear of gun violence. Oh. That you go out and take a walk in your neighborhood, are you going to get shot? Is somebody going to pull up in a car and steal your phone and threaten to shoot you, or shoot you and then steal your phone?
That's real.
Yeah.
So that's a lot to unpack.
Yep.
And I say we may as well go ahead and get to it. But before we get into the individual issues and how resolving them may contribute to our health in a positive way, I'm interested in your delivery of your findings to the powers that be. So you're kind of like a health hunter. You know what I mean? Right. Like you're going out, you're finding ways that we can all be healthy. You've got people like me who are reading your stuff and we're like, oh yeah, this is good. But then you have to deliver that to the bureaucrats, right? And I'm interested in how your findings have been received, or if you were able to transmit them over, and if you've seen any like policy results from your prolific work.
Well, it's
a big question.
Mostly the sound of one hand clapping.
Oh.
But we have had we've had tremendous results in tobacco, freedom from tobacco smoke.
Yeah.
I mean, when I was in training, we used to let patients smoke in bed while they were recovering from a heart attack.
Oh.
And the nurses said, well, you guys only care about the heart, we care about the whole patient, so we let them smoke. But, you're probably not, you may not remember that you could smoke on airplanes.
Uh-huh. Well, we still get the warnings.
Yeah, and you could, there were non-smoking and smoking sections in restaurants. And so you're out having a really nice meal, somebody lights up a cigarette and the whole thing gets blown up. You know? We now have smoke-free public buildings, housing, thanks to Association of Non-Smokers Minnesota. Jeannie Weigum and her team has been one. I think they are the most feared group. The group that the tobacco industry most fears because they're so effective.
Well, kudos to them.
Yeah, I mean, you could smoke at a Vikings game right in the stands, those kind of things. And I used to have to hang my clothes outside when I came home from a trip, and now I, can, go away. I was in Atlanta a few weeks ago, and I don't think I was exposed to a single cigarette any place.
I'm glad you brought up Atlanta, because I grew up in Atlanta, and I moved here maybe 10-ish years ago. And my experience is less in the clinical setting, more in the gay bar setting. And I remember that you could still smoke in bars in Atlanta when I left. but you can't do that anymore now. And as I'm thinking back through, that was not that long ago at all, where you could do all of these things that you're talking about. But it feels like it still feels like we're slow. You know, it feels like, oh, obviously you can't be smoking in the hospital, you know, but they were doing it just a few years ago. And so is your approach to public policy just kind of like slow and steady? You know, you do the research, you put it out there, you make it available, perhaps to those that fearsome group that you mentioned, who you know will take your work and advocate for it. Is that kind of the system you have in place, or?
Right, and particularly with the tobacco industry, expect that they will constantly reinvent themselves, and they will never give up.
Like vaping.
Vaping, exactly. And I just saw, 50% of high school kids have recently vaped or vaped in the last month, and a huge problem with vaping. You know, we used to worry about the filters in cigarettes. These are the quote, disposable vapes that have lithium batteries in them. You know, they're highly toxic, they're plastic, they're all over. They're a huge problem. And then, of course, people can vape a lot of places they can't smoke. I mean, they can vape in class because the vapes they're shaped like thumb drives or this or that. Or
they've got some, and we'll have to move on in a second.
Yeah.
But they've got some that are like a hoodie, you know, and then like you put it in, and then it sends up a little wire, and you can just like chew on your thing.
Yeah, right.
And vape in class.
Right. So,
but we'll move into vaping in particular, and all of the particulars in the next section. I do want to just quickly point out that this year you did author a paper called Describing Racial Disparity in Hypertension Control in Large Minnesota Outpatient Practice. We'll get into racial disparities in general, I think, in the next section, but I do want to say that I'm very appreciative of the work and very interested, because I serve on the Public Health Advisory Committee for the City of Minneapolis for one more month. My 6-year term will be up, unfortunately. And racism as a public health crisis has been really difficult for the committee to get its mind wrapped around because it's so pervasive. It's perhaps more ubiquitous than vaping. And so in the next segment, how about we lead off talking about racism in healthcare, and then we'll go from there. Sound good?
Sounds good.
Awesome. We will be right back with Dr. Tom Kottke. We are back with Dr. Tom Kottke, having a really fascinating conversation on well-being and what we can do to be better people, healthier individually and healthier as a society. I think that's summing up the conversation so far. And we took a break right as we talked about your paper called Describing Racial Disparity in Hypertension Control in Large Minnesota Outpatient Practice, which really asks the question about racial disparities in general. And I guess my first question is why you picked that topic.
Well, I actually didn't pick it.
Oh, you're kidding.
Haitham Hussein was the lead author. He's a neurologist, was at HealthPartners at the time, practicing over in St. Paul, and noticed that, in particular, among black, racially, ethnically diverse populations in their 30s had poor hypertension control. And there's a lot of focus on, 50s, 60s, 70s, those kind of things, but we're not getting that treatment and control for younger folks of color. And what we, as a cardiologist, what I see is heart failure in 30-year-old blacks.
Really?
Yeah. And I never see it in whites. There's something, but we need I mean, what we need is more practitioners of color because of trust, issues of trust. But you mentioned Zeke McKinney.
Yes.
Zeke's a great guy and has done a lot of work on promoting hypertension control. But it's, measure your blood pressure. If somebody says take some pills, take some pills, because these are preventable conditions, and probably the leading preventable, source of heart disease, stroke, heart failure,
Gracious.
those kind of things. Yeah.
So this paper kind of identified a problem.
Yes.
Now we need to figure out the solution. And so in your mind, do you take the paper and then you say policymakers or individuals or whomever, this is a problem in the community?
It's really at all, it's really at all levels. Okay, so the policymakers, and we're at HealthPartners, we're redesigning our hypertension treatment programs. We know, I sit on the Community Preventive Services Task Force, which is a non-federal task force. We meet down in Atlanta, and we've looked at team-based care for high blood pressure control, which helps so a pharmacist or a nurse, basically with a physician, manages patients' blood pressures, and so the patient measures their own blood pressure at home, and the pharmacist or nurse will increase medication as needed, and once they're under control, they get to that control level, they tend to stay in control. And so it's those kind of programs, changing policies within healthcare organizations. There's licensing issues. There's and so it's at each level taking that action that needs to be taken, and then at the individual level of if I had hypertension, or you had hypertension, doing what your care professional told you to or advised you to do.
Now, I want you to take your doctor hat, move it to the side, and also put on your anthropology hat.
Yeah.
Because I feel like some of the causes for hypertension are, what you buy from the store and what you put inside of your body.
Yes.
So there is a tension at the policy level about whether or not you can restrict what people have access to, even when it's healthy for them. Or even when it's unhealthy for them, frankly. We've mentioned tobacco several times. We've talked about vaping. But no one's, I think we started trying to restrict vaping pretty aggressively. And I feel like that's fallen apart, judging from my friends who are just vaping all the time. But if we know that some of these heavily salted foods, for instance, are leading to adverse health outcomes, I personally, as someone who's run for office, am not hearing people say, well, Jerome, we really need to make sure that we're looking at the amount of sodium or what have you that's in all of this packaged foods that's accessible to communities.
Well, I think the stomach isn't here to restrict access to certain foods.
Yeah.
Okay. So there are some movements underway to tax sugar-sweetened beverages, and it's very interesting that sugar is associated with cancers, probably the pathways through obesity. But I haven't really heard about taxing on the basis of salt. Although
you just identified the problem with that.
Yeah. But what we do know is we've worked with something called Super Shelf, and it's using behavioral economics in food shelves, basically starting, the first thing the client sees is fresh fruits and veggies. And they can take those, and then come the frozen fruits and veggies, and finally at the very end, they can get their Chef Boyardee if that's what they want. But the behavioral economics, people do like fruits and veggies. and that's what they want.
This is take me back to the beginning of the conversation with 3-year-old Tom, because it's not just the child looking at the parents and emulating those professions, but it's also food and other behavioral practices.
Yes.
And I completely agree. The answer is really simple. More fruits, more veggies, less red meat.
Yes.
Don't put so much salt on your stuff. Don't buy it. Look at the actual nutrition label and say, oh, okay, do the math. If this is 170% of your sodium intake for the day, then you can't have the whole thing in one sitting. And honestly, you're probably better off leaving it on the shelf.
Yeah.
But we're not seeing any action in that area at the policy level. And we're not really getting those communications in communities, which frankly is why my show is interesting, because I'm the only one talking about it.
Yeah.
But so that's one example. But you've written over 50 papers and done all of these presentations and the like. And so I'm interested in what other topics you might be interested in. I think you've mentioned affordable housing.
Yeah, we know that health, and you've probably, I live over by St. Thomas, and we have this band of right along the river there of pretty much academics from the University of Minnesota, and so people there live along. But then you go over to Dale and University, and the life expectancy is 10 years shorter.
Oh, you're kidding.
No, it's 5 miles. And these are social determinants: housing stability, income, education, and if you have youth who are moving around and worrying, their parents are worrying about where they're going to live tonight or next month, there's not much bandwidth left over for worrying about education. And so we need to create health equity. We need to stabilize housing. We have terrible housing shortage here. And while our overall health status is very good in the Twin Cities, the disparities, I think we're second in the nation after Milwaukee.
Gracious.
Yeah.
So we just had elections in Minneapolis, and I was involved in those elections up until the DFL convention. And one of the big issues had to do with housing instability.
Yep.
Now, the solution a lot of people brought to the table was rent control. And, that is a solution. I don't think it's the best solution. I think the best solution is building more housing.
Yeah.
The price of housing and building housing is out of control. I've complained regularly to this audience about the old house I have with my husband, and we bought the most affordable house in the neighborhood, and it's basically we're basically living in squalor. I tell him from time to time. There was a bat in the house just last night. If you see any bags under my eyes, it's because I was worried about the flying rodents in my bedroom. Oh my gosh, it's a lot. And that's in a relatively expensive house given the income levels of people like myself in this community. And so the issue is very real, very pressing, and I'm not seeing a solution to it in the short term. And what I mean is, we're having conversations about a person's cardiac health, right? And I'm like, you guys, when you go to the grocery store, don't buy that thing that you grew up loving, that you really enjoyed. Figure out how to make something new with the fruits and vegetables that are available. And they're like, well, Jerome, I don't know where I'm going to be sleeping next month if I can't make the rent. And so why don't you just let me eat the soup or whatever that has a lot of salt? And so I feel like the intersection between our well-being and these policy concerns, and whether or not the policy concerns that we end up moving forward with are actually work, is really important.
Yeah. you've covered a lot of
Yeah, I was
territory
long-winded.
there.
The coffee is really working.
Yeah, right. Right. The rent control is a quick, short-term, probably not the best because it doesn't create new housing units. The legislature did pass, I think, allocate $1 billion to new housing.
And we're being taxed.
Yeah, and they're changing zoning so you can have multi-unit housing scattered throughout the city, which should help.
Now that's being litigated in Minneapolis.
Yes, and folks are fighting that because they, we think of ourselves as real good people, but we have a drive towards segregation. I mean, we're a highly segregated community, and we don't have Jim Crow laws, but we have others. We have other ways of, for example, you were able to buy a house, but if we had exactly the same numbers, I'd get the mortgage, you wouldn't.
Right.
No, and that has to stop. We need ways of intergenerational wealth building, but we also need subsidized housing. I am the immediate past chair of Face to Face. We provided wraparound services for homeless youth in the East Metro. Most are Black, brown, or otherwise not Euro-American. And we're going to build a 20-unit apartment building right across from our clinic so that we can help stabilize housing and have the youth near for their treatment. Many having mental health problems, and of course, I mean, they come from trauma backgrounds, and any of us, if we really think it through, if we didn't know where we were going to sleep tonight, I mean, would you have some anxiety?
Yeah.
You bet. Lots of anxiety, and so, and it's 20 units is 20 units, but we need tens of thousands, and it's not just in the city, but also in greater Minnesota. We just need more housing.
So taking the housing, which I love, thank you for your work in that area, and you said youth that you're serving there. How young do they get? Because I know we've also got a Black maternal health
you bet.
concern. And so is it like priority for pregnant mothers, or is it, does life begin at conception and so then you get housing?
Yeah, we care for youth 11 to 24, and it's their statute, I believe, 10 and under, they need youth services. It's a different.
That's the bureaucracy.
Yeah, and we do see pregnancy, young folks with pregnancies, 14, 15, 16, most are a little older than that. One way we need to improve birth outcomes, which are terrible and getting worse, is to see the pregnant people earlier. And we know that pregnant people of color at HealthPartners tend to show up significantly later than Euro-American pregnant people, and so that the obstetricians have a harder time playing catch up, and so establishing that. And so I sit with a group called Healthy Black Pregnancies, and it's Black activists on North Side, North Point, Minnesota Community Cares, Open Cities. It's Wilder, but just in the community, building that trust and helping people understand the value and that healthcare does have value. I think there's a lot of fear of going into healthcare. Obstetrics is a very, very white. So you're going in there and it's like, what are they going to do to me? And so we need, again, it's more thinking of more practitioners of color. And maybe not obstetricians, maybe midwives or even nursing assistants, nurses, et cetera. And they're well-paying jobs. And even a brief period of training gets you in as a nursing assistant and gets you started. And then if, learn while you earn, and going from being a nursing assistant to being an obstetrician.
Do you have
years
any
later.
knowledge, and you may not, about about how sexual health is taught in schools? Because maybe I'm thinking back through some past conversations that I've had here that were primarily relating to infections and STDs and the like.
Yes, yes.
Where kids just don't know that if you have sex, you might end up with an STD.
Yes.
And they also might not know that if you have sex, you might end up pregnant. And they might not know what pregnancy, the symptoms of pregnancy. You know, they might not know how to identify that they're pregnant, and that might be part of the reason why they're not going in to see their doctor if they have one. Yeah,
huge problem. HealthPartners does have in-school clinics. And I just heard this morning from Barbara Cox, our Director of Government Relations, that the most discussed bills at the legislature this year were about in-school clinics and the opposition to.
An opposition to in-school clinics?
Yes, because of lack of parental control and the parents thinking, they're teaching our kids how to have sex. No, they're not. I mean, the evidence is very clear that teaching kids exactly what you're talking about, you have sex, you end up with HIV, you end up with chlamydia, you end up with gonorrhea, you end up with syphilis.
Things that could go untreated.
And you may be pregnant, and you're pregnant at 14. What are you going to do? None of that. It's very good evidence that teaching kids about that, teaching youth about that, does not increase sexual activity. It's hormonal and cultural, and so we need more of that. We need more of that, so that because it's hard enough to break the poverty cycle. It's even harder when you have a kid. And they're expensive. I mean, I have 3 grandchildren. I watch my sons with their partners and their children, and the amount of money they go through is
eye-opening. Coming from a cardiologist.
Yeah, right. Normal human being, it's even worse.
Okay, I do have a soapbox that I would love to get on about teaching sex in schools, but I will leave it there because I do want to talk about gun violence as well. I had a fork in the road in my mind. I was like, do I keep talking about sex or do I talk about guns? We're going to go with guns, gun violence, and in particular, or at least starting with the intersection of the way kids are having to prepare for gun violence in schools. And I feel like that has got to be really detrimental to their mental health. And I worry about how that weathering or even trauma at a young age is going to carry through the entirety of their lives. Is that something that do you already have a paper on that, or is that?
We're working on one. In fact, we're working on one that if you Google gun violence anxiety at the top, you'll come up with a survey that says 88% of Americans have anxiety about gun violence.
Yeah.
Okay, so there's a project called the Global Burden of Disease, and they've worked out how much of your life is consumed by various things, like having a heart attack or mild anxiety. It's about 3%. You lose about 3% of your healthy days. Okay, you multiply that 3% times 88%. You end up with a loss of healthy life that is 5 times as great as the total loss of healthy life from ischemic heart disease.
Really?
At a minimum, and it may be Like we know, I mean, there's good studies that like black kids have 2 to 4 times as much loss. I mean, the prevalence of anxiety, and of course, I mean, I was up in North Minneapolis yesterday and not totally relaxed.
Right.
Because, and, Penn and Lowry, not the quietest neighborhood.
Yeah.
And so we need to do something about this. And it takes persistence. What the pro-gun lobby has convinced people is that there are no solutions. Mm-hmm. But there are solutions. Scotland solved it after a mass shooting. Australia solved it. They haven't had a mass shooting in 30 years after a huge mass shooting. We have mass shootings every day. We have, we're 200 days into the year and we've had more than 200 mass shootings. I mean, it's a more than daily occurrence, but we can solve it. And we need, full disclosure, I sit on the board of Protect Minnesota, which is a gun safety advocacy group. We will be working to get legislation passed that says no guns at places of democracy, polling places, the state capitol. You don't need, I mean, how can you have civil discourse when the guy you're talking to has a loaded pistol on their belt? You don't need that pistol. You don't want that pistol on your belt. If you can't make your point without waving a gun at somebody, you can't make your point.
Now that is the hunter-gatherer in you. There is definitely an organized other side. The Gun Owners Caucus in particular comes to mind.
Yes.
Because I did run for state legislature. And that is the last time I will drop that I ran for office in this episode because I've only done it twice. And I would watch hearings of the Gun Owners Caucus, and they are really adept at, excuse my language, weaponizing the bureaucracy to make it seem like, well, anytime you hunt us and gather a solution and bring it back, they will just tie it up in knots ad infinitum, just forever. And it's really frustrating.
Yes.
Frankly.
But things to remember, I mean, what they'll tell you is because a single law will not solve all the problems, it's not worth thinking about. Well, it's chipping away at it one by one. They'll try to convince people it's hopeless. The other thing they've done, and this happened maybe about 20 years ago, is they've been able to convince more than half the American public that a gun makes them safer.
Oh, sure.
It does not. And people need to remember this. They have this scenario that, if a bad guy comes into the room, I'm going to be able to just shoot him between the eyes. And
right.
Chances are, if a bad guy comes into the room and you have a gun or I have a gun on me, they'll take it away from us and shoot us or hit us over the head with it or something. But a firearm in a household shortens the life expectancy of everybody in that household.
This is a silly example, but as I mentioned last night, there was a bat in my bedroom. And if I was just like out of my mind, screaming and hollering around the house, and there is no way that a gun would have made that solution any better for anybody. And if that little small rodent had me running and screaming, thinking about, buying a new home or something, there are better ways to keep yourself safe, certainly. And certainly better ways for my neighbors as well. Let's take a quick break. I'm obsessed with this conversation. This is amazing. We will be right back with Dr. Tom Kottke. Welcome back. We are having a fantastic conversation with Dr. Tom Kottke. Tom, I've been blown away by your passion for people and populations and all of the work that you've done since, I think you said the 70s, with revolutionary judo is where you started. Unfortunately, we're getting close to the end. We'll have to have you back in the future. But do you want to leave us with a message or something you want to make sure that people walk away from our conversation?
Yeah, I want to talk about improving one's own well-being.
Okay.
Okay, Nato Gwande in his book, one of his books at the end, he says, we've had it wrong all the time. We thought it was all about health and longevity, but it's about well-being, of your daily life, fulfillment in your daily life. Okay, so what can you do about that? Okay, first of all, ditch the habitual negativism of, if somebody asks you, how's your day? You say, could be worse. Okay, come on. There's a lot of good things. So what we know is, first of all, appreciation. Okay, every day identifying 3 good things that have happened. One, like today, the weather is beautiful.
Yeah.
I'm having a lot of fun here.
Me too.
And I'm going to go to a Rondo event tonight to raise money for Rondo. Okay, and I'm going to meet a lot of people I don't know. Okay, there's 3 good things. Second, be kind to people. Okay.
Yeah.
And thank people. Okay, so this is going to improve the lives of people around you. Those people will be happier, and they're going to improve your own well-being. Okay, so we can take control of our lives to some extent. And what's impressive to me is you had hinted at this. Cardiologists make a lot of money. And I'm not in practice anymore, so I don't make all that money. But I've made a lot of money, and not huge amounts, but very big. And I know a lot of really unhappy cardiologists because they get beyond the 8 ball. Too big house, too many cars, too many kids in private schools. Money flowing in rapidly, flowing out, and their life sucks.
Yeah.
And then I met people who should. You'd say, boy, their life is terrible, but they're enjoying life. They have high levels of well-being because they choose to appreciate.
Yes.
And I think, and we know that volunteerism improves well-being for the self, improves for others. And Minnesota tends to have high levels of volunteerism, but I'd say get out there and do something for somebody else, whether it's just your little neighborhood, and picking up the trash or something like that, or something bigger, if you have the opportunity to participate in a board, or through your church. There's a church over southeast, a bunch of young millennials who serve meals to people who don't have money to eat. And they find it extremely fulfilling, this. I don't do that. I get like I mentioned, the face-to-face. I'm meeting people on the board who I would have never met otherwise. It's, I'm going to say, my goal is to make my community the un-Florida.
The un-Florida.
The un-Florida. Okay.
We're running out of time, but we have time for this. I want to tell me about un-Florida.
What is Florida?
Well, aside from the beaches, it's not some place I'm happy going to.
Political repression, racism, limiting knowledge, limiting choices.
It's like a real drive towards ignorance there for some reason.
Yeah, and the oligarchs. I mean, to create this underclass. I think the safest communities where everybody has an opportunity, and they're not frustrated. I had a friend, Roger Feldman, who had studied youth gangs teen gangs in Chicago, and he went back 20 years later, and these guys were all, they had houses and they had a family. He said, well, how come you're not involved in violent gangs anymore? He says, we have too much to lose.
That's beautiful.
Yeah, we have something to lose. And so what we need to do in Minnesota is give people opportunity. They need to have the opportunity. We don't need, I'm not a socialist that says everybody needs the same level of wealth, but everybody needs opportunity, because then they're invested in themselves. And there's youth groups, there's after-school youth groups, there's tutoring. If you want adult literacy, I mean, whatever. Volunteer at the library.
Yeah.
Yeah, volunteer at the library. But and you'll feel better. And then watch what you say when somebody says, "How you doing?" And before you say, "Not so bad, could be worse," reflect. We live generally in a peaceful, generally wealthy community, and we are not in Ukraine. We are not in Palestine. We are not in Central Africa. And so we, just by living here, have a certain human capital wealth.
Yeah. I am, I'm also not a socialist, but I will say once we get people housed, we're feeding the kids now, which I love. I think it'll be so much easier for people, as we alluded to earlier, to invest their time and to serve. And I think it's not just the value of getting people off the street, but also the value that they'll be able to give back to the community and to themselves.
Don't even pay taxes. I mean, there is a business case for everybody having opportunity, because then they pay taxes rather than being on welfare rolls, and they're able to work. Entrepreneurs are able to multiply their ideas. There's a very strong business case for education, for stable housing.
Now you're talking to the bureaucracy.
Yes. Yeah. Now I just have to convince them.
Well, Dr. Tom Kottke, I don't know if I'm going to call you the health hunter or the well-being hunter, but I've really, really enjoyed this conversation. Thank you for your work, all of the papers you've authored, co-authored, the presentations, the reports, the nonprofits, the volunteering. It's really been incredible. Please keep doing it.
I will.
We need it. Okay.
And thank you. It's been lots of fun.
Thank you very much. And thank you all. This has been Bottomless Coffee with Jerome. I'm Jerome. If you didn't know by now, stream all of our episodes at bottomlesscoffeeshow.com. Thanks a lot.